Turning to you, Brad, what are the decision points in the three-step diagnostic formulation at this point? And once you have, let's say, a thought that this may not be normal aging, so you've developed sort of an idea about the cognitive functional status, and then are thinking about the cognitive behavioral syndrome, and you're defining it a little bit, and then you're going forward to determine potentially cause. How do you choose your tests, your tiers? How do you think about that?
Yeah, it really is fairly uniform yet personalized, I guess I would say, in the sense that, for example, I was seeing a patient earlier this week who clearly, the first time he came to me, he had seen others before me, but had dementia. He had given up driving himself. He was in his 50s and was no longer able to work. And it was very clear from the beginning, with the history being provided by his family and not very clearly by him, he wasn't really able to provide it, that he had dementia, and it might not even still be mild anymore. It might be bordering on moderate stage dementia. It was a bit surprising that he had only undergone a more detailed workup at this stage of the game, because it clearly had been going on for a couple of years. And with him, he really didn't have a lot of other medical issues to speak of, and so after some cognitive testing that he performed poorly on, I ordered an MRI and had him come back with his family, and it was very clear that he had cortical atrophy and medial temporal lobe atrophy that was consistent with Alzheimer's disease, and the history was consistent with that. So in him, I felt pretty comfortable with the three-step formulation of dementia, with an amnesic dysexecutive multi-domain syndrome, likely due to Alzheimer's disease based on the history, examination, and an MRI. So in some cases, you can be pretty comfortable with the diagnosis just using what I consider to be that first tier of looking at the brain. I think it's really fundamental that if we're entertaining the possibility of a diagnosis of Alzheimer's or a related dementia syndrome, that we look at the organ that is of interest. And so it could be a CT scan, but I think in most practice settings, an MRI is very readily obtainable and provides much more detailed information, particularly about whether there's also cerebrovascular disease or the common accompaniment to Alzheimer's disease, which is cerebral amyloid angiopathy, that might have already produced some microhemorrhages that can be seen on MRI, but would otherwise be unrecognized, in part because that type of a finding increases a person's risk for a major cerebral hemorrhage, especially if they're given anticoagulant medication. So MRI is useful for a variety of purposes. In more complex patients, like some of the ones that Lili was just talking about, even establishing whether the person has mild cognitive impairment or subjective cognitive decline or mild dementia may require the involvement of my neuropsychologist colleagues and doing the kinds of detailed testing that are available by working with a neuropsychologist. And so that first tier can sometimes really require the involvement of a neuropsychologist or a dementia subspecialist to establish. I think it may also be necessary to establish the cognitive behavioral syndrome to involve a multidisciplinary team of experts, including potentially a speech-language pathologist if the person has an aphasia. And so that may require additional consultations and referrals. And then in thinking about level 3, the step 3, the likely etiology, it's common that even when we think that a person may have Alzheimer's disease or another neurodegenerative disease, that the MRI is not diagnostic, even if you look carefully at it yourself and have training. So in that case, an FDG glucose PET scan can be very valuable if it's accessible in your practice setting, because it's a basic measure of brain function that Medicare approved more than 15 years ago now for the diagnostic evaluation of possible FTD or Alzheimer's disease. So with a Medicare beneficiary, if you're in the right practice setting and have access to this specialized test called an FDG PET scan, which isn't that difficult to access because it's commonly used in cancer monitoring. And so there are often imaging centers that are accessible to most, not even major metropolitan areas, but even some more rural areas that could obtain a brain FDG PET scan, and that often is more sensitive to patterns of reduced brain function that might be suggestive of one of these diseases. And then in more specialized practice settings, you may consider cerebrospinal fluid measures or more specialized PET scans looking for evidence or for biomarkers of Alzheimer's disease or a related diagnosis. So that's when you're really entertaining a concern for these conditions and are considering taking it to the subspecialty level. There are obviously many patients that need other kinds of tests that might be considered second, third, or fourth tier tests, whether they're blood tests, spinal fluid tests, or things like sleep studies, depending on the concern for some of these other conditions that may be medical conditions or maybe brain conditions that could be causing or contributing to the person's overall symptom profile.
So that, I think you make a great point of really targeting it in a stepped way, not doing too little, but and ignoring and not shotgunning everything. And I think we've seen that in practice from our colleagues one way or another. And where you draw that line is really depends on your proficiency and what the patients and families need as far as the confidence in the diagnosis. And I mean, it sounds like, we used to always hear that Alzheimer's was, a diagnosis of exclusion, that we weren't sure, but it sounds like it's becoming a diagnosis of inclusion with some of the tests and biomarkers you mentioned. Mary, you had mentioned the cognitive lab panel, and Brad mentioned the MRI. So do you send those in your practice, and what blood tests would you send as the first tier?
Yeah, absolutely. So I think when we have someone that comes with us with a cognitive concern, there is a group of labs that we generally would recommend, mainly looking for other things that could contribute to cognitive loss, and things like just a simple CBC. We alluded to dementias, the blood anemia, a CMP that would look at kidney function, renal function, and electrolyte abnormalities, hypercalcemia that could all potentially affect cognition, thyroid testing, vitamin deficiencies, B12, folate, markers of inflammation, homocysteine levels, all of these may contribute. It's rare that we find a truly reversible cause, but frequently we will find other contributing causes. And I agree completely with the brain imaging. To have an MRI is, I think, gold standard for most. In my practice, I have a lot of very senior patients that, for other reasons, may not be able to or refuse to do an MRI. So at least having a CT scan of the head, I think, is essential in any diagnostic workup.
Great. And I know that due to participation, there is, for the first time, the Alzheimer's Association is putting out the clinical practice best guidelines for evaluation. That sounds like it'll be out early in 2020, which actually gives a stepped approach to the diagnostic process, evaluation process, including what to ask and specific recommendations about tests and when to use them. So that's something we can all look forward to seeing.